Welcome you all in this case control study lecture. In this lecture, we are going to study what is a case control study. By definition, it means that it involves the identification of individuals with cases and without those cases we take them as controls. So the prevalence or level of exposure to a factor is then measured in each group, and if the prevalence of exposure among cases and control is different, then it is possible to infer that the exposure may be associated with that particular disease in question. So, as we have studied, so let's go for an example. Over here, the example says that the relationship between use of conjugated estrogen and the risk of endometrial cancer was examined among 188 white women aged between 40 to 80 years with newly diagnosed endometrial cancer, which you can say it's uterus cancer, and 428 controls of similar age hospitalized for non-malignant conditions requiring surgery at this hospital were taken as controls. Okay, so the data on drug use and reproductive variables were extracted from hospital charts and from the medical records of each individual woman private physician. Okay, so 39% of the cases were associated with that use of drug, the conjugated estrogen in question, and this incidence was high among those uterine affected patients when compared with the controls, with out of the 20% controls. So in this example, what we are trying to infer are the two core things. Number one, we started this study with the uterine cancer affected individuals, and we take controls from the same hospital. Now the controls are our options. We can take it from the normal population, but for our A's, we have collected those individuals which are visiting the hospital for some other medical condition which is not related with the disease in question. Okay, so that's the simplest form of case control study. Now, what are the plausible applications of case control studies? The first foremost application is it is particularly suitable for the study of relatively rare diseases with a long induction period like cancer, because case control study starts with the subjects who have already developed the condition of interest. That is important because we are studying, in our previous example, we have inducted uterine cancer affected patients, not the population has been studied for a certain period of time and then we study what are the possible cases we are going to eliminate. We just hit to the individuals which are already affected with the disease. So undue wait for a time to initiate is reduced as noted in a prospective cohort study. So that's the difference. In cohort study, we take a population and then wait for the plausible signs or a case to infer within a certain time frame. In case control study, we simply jump to the cases and then compare those cases with the relative controls, and then we try to identify the possible question that whether this particular exposure has any association with the disease or not. Okay. Now, look at this example. A population-based case control study was carried out in Spain and Colombia. Okay. Now, to assess the relationship between cervical cancer and HPV, and along with that, several sexual and reproductive behaviors, use of oral contraceptives, screening practices, smoking, and other relative exposure factors are being evaluated. Okay. Now, the study includes 436 incident cases of histologically confirmed carcinoma of cervical cancer, all right, and then 387 controls. Okay, now if we look at this example says that the population-based case control study was conducted. That means the study is conducted on a huge population, but that population is also defined as cases and controls. So the cases were taken from two different populations. Number one is the Spain, number second is the Colombia. So the difference between Spain and Colombia is of socioeconomic variations. And then these socio-economic lifestyle differences are also compared, that whether the difference is because of a person understanding, schooling, smoking, or parity, because both these nations have different lifestyles. The Spanish population has different lifestyle in terms of parity, in terms of smoking, when compared with the Colombian population. Okay, so it is a case control study happening among the two different populations, but the objective of the study remains the same: to identify the probable exposure factors or among the cases and define whether the smoking has any association or any other thing. Okay, so this is another example to infer and define our understandings. Now this problem falls with the cases. Now, what is the selection criteria for a case? That's the precise criteria for the definition of a case is essential. It means that the person who is visiting a hospital is inducted in this study, or is being questioned based on, then we are going to refer it as that the person individual in question is being evaluated. For example, if we are talking about, let's say, the COVID-19 infection in time with the recent outbreak, our foremost interest would be to identify already confirmed individuals, not based on sign and symptoms, but maybe you can say based on CT scans, based on PCR reports. We identify and include all those individuals which are COVID-19 positive, but we omit those individuals which have a mild symptom of flu, cold, or have sore throats. We exclude those criteria so that our cases remain very precise to the question we have in hand. Okay, so histologically confirmed diagnosis should be required for most cancers. And then we are saying, by accepting less well documented cases, the investigator increase risk of diluting the case group. Like for example, in COVID-19, if we are including every individual who is suffering from cold or flu or sore throat, so the risk of diluting the case group is increased. So we believe on definite diagnosis rather than probable or possible means. Okay, so the cases should be restricted to those who have some reasonable possibility of having or had their disease induced by exposure under investigation. That's important. Now, looking to this example says that a multinational hospital-based case control study was conducted to evaluate the relationship of combined oral contraceptive use to the risk of developing 5 different site-specific cancers. Okay, so the study was designed on oral contraceptive use to try to evaluate what type of cancers, 5 cancers, may possibly be affecting the individual, and the study was conducted in 10 participating centers of 8 countries. So it's a large study. Now, women with newly diagnosed cancers of breast, uterus, cervix, ovary, and liver were eligible. Okay, and depending upon the use of oral contraceptives which were locally available, these patients were being induced. Now, if you look at the study, it says that the women who were born between 1924 to 1929. Now, this is important. Why? Because those individuals, those women who were born prior to 1920s, are much older at the time of this study begins. The selection criteria remains the same because the availability of oral contraceptives is more useful for the women of younger age rather than the older or elderly women where there is already a menopause. So, though the study was conducted in 1979, but the selection criteria of enrolling the women's is age bound, and this age bound limit was checked by the condition of women's birth between the duration of 1924 to 1929. So this is a case selection mandate example. And then incidence versus prevalent cases. Now this is important in an aspect that the core element in this incidence is we are trying to induct as much as newly diagnosed cases irrespective of the prevalent cases, because the prevalent cases may give us an example or relationship correlated with the exposure survival. How many individuals survived because of any particular disease pressure. So incident cases are all new, occurring in a population within a fixed period of time. prevalent cases are all existing, new and old. The main disadvantage of using prevalent cases series is that with the long course of disease tend to be overrepresented, because in this case if we induct already enrolled prevailing cases, the number of exposure is already been exaggerated with this respect. So let's say we are in trying to decipher this example. I'm going to quote this in my further lecture. Now the source of case recruitment are mainly two: the hospitals or the registries or record databases. For example, if we are interested to know about the COVID-19, the sources remain the same: hospital or cancer registries, because they are more reliable. Now the control criteria. The control criteria is what you can say, it's a very user-friendly format. The controls eligibility criteria is almost the same as defined for the respective cases, with one condition: it should be disease-free. The disease in question should be not present among the controls. For example, if we are working in breast cancer, the woman age should be matched, but the women who are free from breast cancer are ideal to be enrolled in this study. Else, we can use the individuals who are not suffering from breast cancer but may be suffering from certain other ailment. For example, in most of the hospital-based studies, if we are trying to study, let's say, the association of pancreatic cancer with caffeine intake, and we compare the caffeine intake patients have increased risk of pancreatic cancer and compare it with the individuals visiting that hospital with some other ailment, with, like, for an example of gastrointestinal disturbance, or let's say for a UTI infection, urinary tract infection, they can be taken as our controls. But obviously the data may be slightly biased, but we can take them as a control. Okay. For example, for breast cancer, the age of 45 years and above, the controls must be selected from women in the same age group without the disease. This is important in terms of age. Why? To differentiate between menopause, premenopause, and postmenopausal phases. Now, the sources for controls, as I have mentioned, you can take the general population, or you can take the hospital based, or you can take a friend who is also engaged, or you can take an affiliated individual who is also visiting the hospital as, or a physician, because he already know the disease and he has been living, or it's what you can say, sometimes you take control of a neighbor because he is also living in the same socio-dynamic or socio-economic culture, so the factors won't differ by and large. So the relationship, let's say the relationship between H. pylori infection and gastric carcinoma was examined among the Japanese American men living in Hawaii. A total of 5,000 individuals were enrolled. At that time, each individual provided a blood sample. By 1989, a total of 109 cases of pathologically confirmed gastric carcinoma has been identified. Okay. The stored serum samples from all patients with gastric carcinoma cases and from the selection of subjects who did not develop gastric carcinoma were taken as controls. So this is like a sort of smart strategy. For example, I have taken the blood of I have taken swab of the whole class, 17 individuals at this time point, and then after 4-5 months I say half of you, God forbid, suffer from COVID-19, so I take those COVID-19 as cases and compare rest with the controls. Okay, so this sort of study, which initially looks more like a cohort study, is being transformed to a case control study based on this information. Okay, but generally based on this information you can say that the case control study begins with the identification or enrollment of cases, comparison with the controls. Now suppose, now this is an interesting example over here. If you look, that we are interested to see that suppose we begin our study from this time point, the time point at the what you can say leftmost side, which says initially at risk, disease free point. So say we have 200,000 individuals, healthy women, and they are followed up for 10 years to assess the relationship of lifestyle variables with the development of various types of cancers. And during this follow-up, we came to know that unfortunately 60 new individual cases, 60 individual women were affected with the disease, okay, and the rest, so out of 200,000, rest 199940 are still at risk of attaining any cancer. So there are three things we can do with these numbers. Number one, we can identify the incidence of a disease. We can identify the odds of a disease, or we can identify the prevalence of a disease. Okay, so for finding out the incidence of a disease, we take the new cases. So at the time point, if we say at the time point in new cases of disease is 60, the denominator value will be changing only. The numerator remains the same. So 60 divided by 200,000 gives us the values. And similarly, the still at risk individuals, if we divide 60 by 199940, that's the odd ratio we are going to get. Okay, so this is how we are going to attain certain incidence, prevalence, or risk ratios. Similarly, the example for matching is important. For example, if we are comparing COVID-19 individuals among with the non-affected COVID-19, we should ideally go for a gender-based match, age-based match. So it's called stratification of our data. For example, the number of individuals who are present in my class are 17. 8 of them unfortunately got affected with COVID-19. Now I match those 8 with the next 8 based on gender, based on age, based on the possible socio-economic clear. I mean the level of exposure. If they are married, then I am going to compare the parity status as well. So this case control stratification bar is being made. So matching is related to the confounding factors. Age, sex-based confounding factor is set forth. Like over here, if you look for the example, it says oral contraceptive use compared with the age, and then when we are comparing it with the ovarian cancer. So the triangle says we are interested to see whether the use of oral contraceptive have any association with ovarian cancer. In order to know that, we are also taking an account of age, the age of an individual who is using this oral contraceptive. Now there are two additional questions which come in anyone's mind. How much dose she's going to take? Is it going to be 5 pills, 1 pill, or per week? So the dose and duration of that intake is also being of our interest. Similarly, for hepatitis B virus, chronic liver disease, and liver cancer, the frequency of matching is sometimes more important. Irrespective of, we can say that based on our estimate of number of individuals who are affected, 8 in COVID-19 positive cases, we say that let's match these 8. Let's assume that those 8 individuals are males. So we say we are going to take 8 male as normal controls. So it's a sort of frequency matching irrespective of age. That's another art of comparison. So the measuring of exposure, data on relevant exposure can be obtained by certain means. For unbiased information, the element of biasness is always present. The element of biasness means sometimes we as an observers are biased. We categorize those individuals as diseased or as controls. So, or sometimes our interviewing person doesn't have sufficient what you can say memory in him, so a recall biasness is also present, and recall biasness seriously affects our results. For example, if we say and we are interested to know the association of caffeine intake with pancreatic cancer, and we compare it with the hospital based visitors, the visitors will always be conscious about the intake of caffeine. When we question them, they are not going to say they are heavy caffeine drinkers. They are always going to say, okay, I used to drink coffee, but now I have reduced the number into a very substantial amount. So the data is already, I mean to say, high in certain aspects or low in certain aspects, because based on the advice of a physician, based on certain pre-advice, those individuals which are being taken as controls may already calibrated their caffeine intake. Got my point? This is called recall biasness. And sometimes they don't mention that they are taking alternate forms of caffeine, and they just say, oh, I don't drink coffee, I don't drink tea. So this is how we can say, or the person, if we ask about the smoking, he or she may say that he has quit smoking. And if you ask, when? And he says, last week. And how long you been smoking? 10 years. So you won't categorize them as negative smokers, or you will try to gauge them on the basis of dosage and exposure. So this is called data stratification in case and control study. Next comes the analysis. The analysis part of a case control study is done in two aspects: unmatched and matched individuals. Unmatched we are going to study first. So in unmatched group, it is again this shows that in cervical cancer case control study, the distribution of variables between the known risk factors of cervical cancer were examined among cases and controls as shown in the table. So the study is already the same: Spain and Colombian population. These are the cases and their controls, and then they are compared with the Colombian cases and controls. Okay. Now this is an unmatched and frequency matched study. Why? Because we are taking two different populations, Spanish and Colombian, and then we are matching those findings on certain socio-economic, age, schooling, education parameters. So if we look closely, and I want you to look at the numbers of schooling, the number of individuals who ever visited school is 162 in Spanish population, and in Colombian population it says 155. All right. And then if we say that the number of individuals who never visited school cases are 88, if you look at the schooling never under Spain column 1, 88, and then they say in controls 59. So for unmatched studies, we are going to calculate the odds ratio. For the calculation of odds ratio, we are pulling both Spanish and Colombian cases together. Okay, so what I am going to do in the next slide is I am going to pool 162 plus 155. So the cases are being pooled over here. These are the total number of cases. Then I am going to compare it with the exposure factor, whether schooling has any association, exposure, or non-exposure has any association with cervical cancer. So over here, if you look, cervical cancer cases with the schooling factor, never exposed or ever exposed. So 199, ever exposure 317, controls 68, ever is equal to 319. So the data says I am combining the cervical cancer cases, never. For the never term, if we look back, never term it says 88 plus 31, that is the value of 119. Never 119 is being derived from Spanish and Colombian cervical cancer cases summation. Then for odds ratio, the values are being described as A divided by B with a large denominator of 68, yani C divided by D. That's the odds ratio. So based on this odds ratio, we assume that the schooling has a strong association with the cervical cancer incidence. This is we infer the risk factor of cervical cancer is strongly associated with the education. Similarly, we can count on parity, number of sexual partners, oral contraceptive use. Okay, so this is how we calculate odds ratio. Now, in the second part of analysis, where we are talking about individual matched cases. Now this is slightly tricky. The tricky part is, if we like I am working on breast cancer, so and sometimes the surgeons excise me a tissue which contains a tumor portion, but it lack a normal background tissue. So that part doesn't contain an appropriate match. And sometimes I came across a surgery where surgeon gave me both the tumor affected region as well as normal background tissue. So I have contained an individual matched case. Okay, so I have a patient where I have a controlled background tissue as a normal representative, and I also have a tumor part. That part I have been elaborated as exposed. Exposed is labeled as AR. So a case exposure tumor background also contains not only the tumor as well as control exposed. So I have 2 plus, which is labeled as over here as R. The S region indicates case exposed. I have a tumor, but I don't control the but I don't have a control. I don't have any adjacent background normal tissue of that patient. Maybe lost, maybe the surgeon forget about it. So I have that part, and this is called unexposed control. Okay, then the case not exposed, okay, for T, but I have a control exposure. So the control individual may contain certain portion of it, but the case doesn't at all have any representative data about it. And for you, it says neither the control nor the case is being exposed to any particular factor. It may be a random biopsy of any other thing. Okay, so I don't have any particular information about the tumor in question I am talking about. It is just a normal piece of a meat, what you can say. Okay, so in order to compare it, RSTU, individual match cases, the strategy is different. And the strategy says for individual matched cases, I'm going not going to read this whole question, but it is basically saying comparison of sweet intake with bladder cancer. So it is comparing these two values. For this comparison, the answer for this question is pretty straightforward: matched ratio, and we are comparing S divided by T. So unexposed controls or unexposed cases are being studied with this T value. So 87 divided by 73 is called matched odd ratio. And then we are going to say whether the effect of sweetness has any association with bladder cancer cases or not. So in individual matched cases, the most ideal data would be of those which is missing. That's important. So in conclusion, what are the advantages of case control study? 3 points. Efficient in time and cost, because we don't have to wait for a very long period till the outcome of a disease to begin. So we just jump up to the individuals who are already suffering from a disease as compared to a cohort study. So possibility to investigate a wider range of possible risk factors. Good. Particularly suitable to investigate rare diseases or diseases with a long induction period. In case of cancer, we usually assume the cancer takes 5 to 10 years to become evitable or clinically evitable. So a long induction period is being reduced. We can take multiple lifestyle factors. What are the disadvantages? The disadvantages are selection biasness. We are always biased regarding disease and risk factors. Then the recall biasness while interviewing most of our controls or even the patients may are not in a position to truly share the data with us. Or the temporal sequences between exposure and disease made difficult to establish. Reverse casualties, like the individual may be suffering from other ailments and he is just saying that this is the factor which is responsible for the disease. For example, in case of and the individuals who are suffering from any ailment during the stillbirth problems, most of the women may blame that there is a full moon, there is a half moon, or they say that there is a flu, or there is a severe, what you can say, any other factor contribution which is influencing, while the real cause may be something else. So this is called as reverse causality problems. Okay, hope you understand it well. Thank you very much for your time and attention.